Thank you very much, Dr. Anula Vijayasundara, the chief guest, Prof. Anjana Silva, the president of the Anuradhapura Medical Association, members of the head table, and honored guests. Thank you very much for giving me this honor to present the keynote at this session. So my story builds on what the chief guest, Dr. Anula Vijayasundara, mentioned. I am going to argue for the single story, that's the case reports, and the importance of case reports, and why it can be worth 1,000 data points in some of the research we do in the universities. You might wonder why I am speaking like this, having been in the university. Well, unlike Anjana, I have never won a huge research grant. I have done most of my research with almost zero funds. And if you want to see whether I have succeeded, I may have succeeded because I'm in that 2% in that Stanford citation. So that's with zero cost, no major research programs, only clinical acumen and using my brain probably. Yeah. So the single story argues for the value of case reports, what we do every day. And Anula beautifully described how case series are useful. And we still look at her work when we want to speak about malaria, snake bite, Shigella, and Japanese encephalitis. And we have Professor Nimal Senanayaka's relative here, Himal, and Professor Nimal Senanayaka, he published groundbreaking research. He described the intermediate syndrome and also the peripheral neuropathy with gingerly. And those were based on case reports, and then he made his observations on case series, and they were published in the New England Journal of Medicine. That's the level he went to, all clinical work. So I'm going to go into depth on this case reports. We use the term case reports, but these are about human beings, but this is the jargon we use, right? So it's more about the person. I hope you recognize these three. You may recognize one person, but you might not recognize the other two. In the middle, of course, is J.R. Javardhana. And what's the case report got to do with that? I'll show you. Then on your left is Bloom. Benjamin Bloom, who was an educationist, educational psychologist, who talks about the cognitive domain in learning. See, when you try to teach medical students also, you have these three domains: cognitive, skills, and attitudes. And in the cognitive domain, that's to do with thinking and so on, you can have a hierarchy. So you have very simple things like MCQs where you recall facts. But clinicians, we have to apply our knowledge. And when we diagnose, in fact, we have to create, synthesize. It's a different cognitive domain. So why case reports promote the cognitive domain? And then on your right is the philosopher of science, Karl Popper, who talked about the advancement of science. Science advances by falsifying. So until, for example, if you say that all swans are white, so now you can see millions of white swans, and you have confirmed that it's white. until you see a black swan. The moment you see a black swan, you have to dump your theory and you have advanced, because swans can be white or black. Right? So he came up with this notion that if you want to really advance science, you have to falsify, not confirm. We are used to confirming. Politicians confirm what they say by giving evidence. No, if you really want to advance, you have to falsify. And then you find that you have to think of something new. So, the case reports, I think, have something to do with all these areas. So, let's look at the cognitive domain, and I'm going to use a single story here to bring out this. These photographs are from the net and they don't depict the person. Right. So, the gentleman actually looked somewhat like this, and this is a patient I just saw 2 weeks ago, right? Hot off the press. Just goes to show that if you really go into depth, you can produce a case report every week. I'm telling you, you have so much of material here. And Anulam described to you some of the material she had noted. Okay? So he was brought like this with the dropped head syndrome. He could hardly look up. And he was 92 years, and his main complaint was that he couldn't really get up from his seated position. Prior to that, he was managing. Though he was 92, he was absolutely lucid. He was very clear in his mind. An active 92-year-old, except that he had a dropped head syndrome, but now over the past 2 weeks, he was finding it difficult to stand up. And he had numbness of his hands, and for some reason, the investigations done was about a carpal tunnel syndrome. I still can't understand why the difficulty in walking or standing up was not tied to the numbness of the hands. Then he was also on treatment for diabetes and dyslipidemia. So now I'm going to challenge you on how this case evolved. You can also take part in it on your own. So this was the basic structure, cervical myelopathy and worsening cervical myelopathy, because for years he's been having this, and I assumed that it was getting worse. That's why he couldn't really get up. But there were other causes. Can you think of other causes why he should be finding it difficult? Right? I was wondering whether it could be diabetic hematrophy which was coming in. And also, elderly people, if they do get an infection, you would have found that off legs, that's the commonest feature. Right? UTI, and they can't walk. So these are the two things which went through. Of course, I got an MRI done, and you'll see a critical compression is now being seen by Stravinsky Pereira to try and do something, right? That's critical. Unless you do something, he would have quadriparesis. But having said that, what could have caused his dropped head syndrome? That's something we had not thought about. And of course, it could be motor neuron disease or some sort of myopathy. Okay? Is there anything in his history which could account for his myopathy? Statins. Statins, well known to cause some odd myopathies. They can come with cramps, but sometimes you get a myopathy which can only be diagnosed with a biopsy. And he was still on statins, 92 years of age. So the first thing you do is to stop the statin, right? And he has diabetes and hematrophy. And any clue from this to account for his difficulty in standing? Vitiligo, autoimmune disease, B12 deficiency, subacute combined degeneration of the cord. Okay, right? So that was on the cards. Then he's 92 years, already almost in a wheelchair. 92-year-olds won't go out in the sun. Could be vitamin D deficiency, which causes weakness. Any metabolic cause for his weakness? He has diabetes, could be CKD, and with that vitamin D levels going down. And if you have CKD, can there be other causes, metabolic causes of weakness? Yes, it could be hyperkalemia. And if he was given an ACE inhibitor, potassium can go up. We've seen people coming with paralysis sometimes, quadriparesis, to find that the potassiums were 6 or 7. So that's well known. Now, this is something which I did actually in my prior practice. So you might not be able to do all the investigations, but at least this patient statins should be stopped, vitamin D should be started, vitamin B12 injection should be given, and referred him quickly to a neurosurgeon. This is a way of looking at what we have reported as synthesis. So your case reports can be used to synthesize knowledge. And that is a key cognitive skill which we have to develop as clinicians. Going to be more important because AI won't be able to do that. AI will not do this for you. Right? They can synthesize some of it, but they won't really be able to synthesize based on context of that patient in front of you. Because AI will have a list of symptoms and signs, and will go through all the literature, especially from Caucasian Europe, because that's where the literature is, and give you an answer which is relevant to those countries, not necessarily for us. And Anula mentioned so many facets of tropical diseases which you see here, and I'm so happy that you all are having a new journal on tropical health from the Anuradhapura Medical Association. So that's where Bloom comes in, because Bloom came up with the hierarchy of cognition, of thinking in education. And when you do synthesis, you are right at the top. You are not at the MCQ level. Your guidelines are pretty low. It might be good evidence, but you see, unless you diagnose, you can't apply your guidelines. Unless you synthesize, you can't apply any of your meta-analysis. You have to say what's happening in your patient, and then there will be books and books telling you what to do for each of the diseases. So, case reports, key important thing is that it helps your learning. Two other quick synthesis, examples of synthesis. patient came with overdose, has taken an overdose of metformin and taken kerosene. You will never get this elsewhere in the world. Who is going to drink kerosene and take metformin? So now we could have easily written it up as the first case of kerosene and metformin poisoning. No, we want to synthesize it. We wanted to see, because if you take excess of metformin, you get acidosis. When you take kerosene, there isn't much literature on kerosene, but we know that it affects the oxidative pathways, causes seizures and so on. So we tied both together, and our synthesis was that this acted synergistically, and therefore he had prolonged acidosis and hypoglycemia. No one can falsify that, because no one else is going to drink unless you do this study in animals, right? So again, synthesis. And it was published in one of the journals. Again, the patient came, a young person, 30s, with this teeth. And he had a dissected aorta. So he came with dissection of the aorta. And when he smiled during the ward round, I said, yeah, teeth are odd. That's Hutchison's teeth. Now, why do you get Hutchison's teeth in syphilis? You get it in congenital syphilis. And with syphilis, you also get an aortitis. So our interest was to try and tie up the two. I don't think we did a good job of it, but anyway, we wanted to tie up the two. And unfortunately, this has been published in a journal which has now gone defunct. I couldn't get the original paper. So again, synthesis, very simple clinical observation, which helped us to look at that. Now, J.R. Jayawardena comes in because of what we call narrative synthesis, narrative competence. So I mentioned about, Anjana mentioned about humanities. Yes, in medical humanities, what you want to do is to use the arts and literature and narrations, patient stories and so on, to learn about the human being. All right? And this patient who saw me 2 weeks ago, highlighted narrative competence. Because I will explain why it was a narrative training for me. So after telling me giving me the history and things, he was very, very lucid. So I asked him, "Mata mokadda karapu raksawa?" So I'm a teacher kenek. So I said, whenever a teacher or someone comes, I respect. Any elderly person comes in, I respect. I sometimes stand up from my seat. And then I asked him, then he gave a whole list of places where he has worked, including around Anuradhapura, Kataragama, all over. So I asked, and then the son said, "Osa meara Julie Varjakek." Now, some of you are not born. In 1980, you see, J.R. Jayawardena came in 1977. In 1978, he brought in a lot of free market, and the workers revolted against this. And there was a huge strike called the July 1980 strike. 40,000 people lost their jobs. A lot of them committed suicide. And there were hundreds of government servants who was sent on punishment transfer. So he was a punishment transfer guy. Fascinating. Because the moment I said, Julie Vadavarjakeda, me JRG Kalaneda, his eyes popped up. He was dropped head. But you could see, I have made a different connection with him. Completely different connection. Because I have now spoken to the human being who has gone through all this experience. All this is within 15 to 20 minutes, right? This is not a 2-hour consultation. And he narrated the story of what happened in July 1980. Then he told about his school. He has been in Olcott school. Immediately I asked Anand, I was from Ananda. I said, students used to come from Olcott to Ananda. He said, yes, I also came to Ananda. And I did my SSC in 1960s. Another connection. So that's what you call narrative competence. Again, case reports will give that. Your dots in the research will not give you that. Falsification was the third one. And this is where Karl Popper comes in, the philosophy of science. And I'm using Sri Lankan originals to drive my point, because I want you all to be able to do this. So liver fibrosis from hepatitis B infection was considered irreversible. And a precursor for this was what they, in the 1980s, we used to call bridging necrosis, which turns into fibrosis. And even as 2001, there was this debate going on whether it is reversible. Right? And later on, they found that antivirals help to reverse early fibrosis in hepatitis B. But way back in 1981, Jaffna Medical Journal, and the gentleman there is one of my mentors, Professor Shanmugam, who was a professor in medicine. He did biopsies in a patient before and after hepatitis B, and showed that the bridging necrosis had receded. So he basically falsified an existing belief in hepatitis B. I happen to be his registrar, that's why you see name number 2 is KSA Jayasinghe. Right? And I've learnt about case reports so much from him. And similarly, you can have these cases triggering your curiosity, and you do case series, and then, as what was described previously, you can then falsify some of the hypotheses you have. Cracked skin of feet is considered rakte, and you see it so commonly. No one looked at it in detail. We had a look at it and we thought it's something to do with walking barefoot, and we still don't know what's causing it. The hands are of a person who came, had pigmentation, and then we realized this could be arsenic poisoning, and confirmed that it was arsenic, and then did a case series, because all these people who had similar pigmentation were opium dependents, and the opium was getting contaminated with arsenic because it was being brought in containers, smuggled from India in containers which had arsenic. Manioc leaves are given there because Dr. Priyantha Atapattu, who is now in the Ministry of Health as one of the Director Generals, he was the DMO at Badal Kumbara when we visited him on a research project, and he said, "Sir, me hariyata mehe vayu gedi tiyenawa hariyata innawa," and his ward was full of people having goiter. And then he said, "Sir, me කට්ටිය මම නම් කියන්නේ සර් මේ මොකක් හරි තියනවා මේ දලු කනවා මඤ්ඤොක්ක දලු." That manioc leaves during the time when the crops were failing, they used to rely on manioc leaves. And actually there's a cyanate in it which inhibits iodine, right? So an observation by a DMO in the front line. And the other case series was to look at people who were having wounds in their diabetic wounds. If you read the literature, they'll talk about ill-fitting shoes and so on. But in Sri Lanka, the problem is no footwear. It is not that you are wearing footwear and the footwear is ill-fitting. There's no footwear, which is different. Because your public health message then is different. Wear something, not well-fitting DSI. Wear something. And again, we did a case series, and all these were published. So what I have tried to impress on you is that a single story really helps in cognitive aspects. It helps in learning about narrative competence, which helps you in your clinical care. And also, it can be used for advancement of science, because your patient might really falsify an existing problem, like what we did with the hepatitis B. Though I'm coming from the university, and with apologies to Anjana, you see, clinical trials to me don't give this. See, and this idea that we should be making practicing clinicians competent in clinical trials and hardcore research, I think is not correct. Clinicians should know about research, should know interpretation of research, should know the principles of research, but they should be masters at clinical cases, in case studies, in case series, and you've seen how they improvised in Polonnaruwa and saved patients. When you do clinical trials, it is very rare that you will be having the original idea. I mean, there are rare exceptions. Anjana is one. But mostly, you'll be doing someone else's trial. Someone else has thought about the hypothesis. And basically, it's drug A is better than drug B in condition C. To me, that's a no-brainer. That's not going to improve your cognitive skills. Probably in Bloom's taxonomy, that's fairly low down. And invariably, you'll be just collecting data. That's why data points. You'll be typing in data. So for me, it's very clear, right? If you look at case reports and clinical trials, clinical trials is boring compared to what you are doing every day. And it's very important that your journal pushes for good case studies, not case studies which say this is the first case in Anuradhapura or Sri Lanka or in the world. That's also okay, but that's not that's okay to flag, but that's, you would see that's not a high up in your cognitive domain, right? That's just saying, I've seen one case. So it's very creative if you really challenge it. And what's the implication of this is very serious, because our PGIM is pushing for research. See, that's because, I'm going to be controversial here, that's because the PGIM is dominated by academics. In the universities you need research because you have to do the clinical trials, someone has to do the clinical trials and document and so on. But while you maintain that academic rigor, what we need are experts in case studies, experts who are able to synthesize, experts of people who will find it enjoyable to work in these hospitals, apply their knowledge right in front of your patients. The thinking processes, the narration, advancement of science, all done with your patients. So with those words, I thank you once again for inviting me, and congratulations on you, and congratulations to the previous president as well as the team which had done a wonderful amount of work, and I wish you all the very best. Thank you very much.